patient care. And I'd just like to welcome him. I don't know what JD's technically, I mean, I know you're a lawyer, but I don't know what your title is. Do we have to call you Esquire? Marty? Oh, okay. Well, anyway, welcome, Marty.
Yeah, that's the third doctor. Thanks, Dan. I appreciate it. So I'm going to talk today about patient and family engagement, which is a big wave that just is like coming across everything in healthcare transformation. There's a lot of theory about it. There's a lot of kind of different streams of patient and family engagement that are getting organized around the transformation work from CMS. I'm going to try to make this as practical as we can today, but I'm going to really echo what Tom said. I mean, we're going to be working together for 4 years. My opportunity today is to give you a little orientation about what's happening nationally and kind of the drivers of this. So there is going to be some didactic stuff. But as we move forward, it's going to be communities like us that are really coming up with the tactics, implementing them, seeing what works, seeing what makes sense. There's already a lot of garbage out there, along with a lot of really good stuff. So part of what we're going to be doing together as a community is just use the word what we call sense making, like basically culling the wheat from the chaff to just kind of figure out what can we work and what works in our community. And I appreciate the introduction, Dan, but I am very excited to be here. I am in North Dakota, and I am involved in a lot of these campaigns. I've worked with Tom for a number of years on the end part. Actually, Tom and I have known each other for longer than that. But the Midwest, I think, really does have a lot to bring to this. The Iowa Healthcare Collaborative amongst the PTN has just earned credibility nationally because we get things done. And I think, especially for something like TCPI, when we're working in small communities like this, I mean, that us, them, that's the patient that doesn't follow directions. I mean, that's us and them and us. In our towns, the patients and families are our relatives or our employees. I mean, we know the people in our hospitals, we know the people in our clinics. So a lot of what patient and family engagement is about is building stronger relationships and then kind of supporting each other in those relationships and figuring out how to do it when there's real barriers that people face because they've got special needs. The other thing I want to say just before we get into the slides is that we're really because it does feel to me like there's a real opportunity for transformation here, not just in payment, but in just the way we think about medicine, the way we think about physician-patient relationships. And that, has to do with Don Berwick, but it also has to do with just we have a really, really old model of the patient's job is to follow the directions of the doc. And that might have made sense in the simpler time when you had one doc and you had 500 medications to choose between. Pretty much all carry them around in his head and knew who diabetes patients were. But we have like a really complicated healthcare system now, and we need patients and families to be our full partners, to be co-producing, and that really is the gist of all this work. And again, I think we're going to find stories in your community, in your practices. I already last night downstairs having a glass of wine at the end of the night, talked to Susan. Fantastic. Susan has a son with special talents. He had to go for an operation. So, by the way, when he's under anesthesia, get some dental work, get him a haircut. So those are really traumatic situations. It's that kind of relationship-based customization that is where CMS wants us to go. CMS does not know how to get there. They're going to be looking for the answers in rooms like this. People that so, super excited to be here. Appreciate the opportunity. So, I'm also a little sight impaired, recovering from 2 years ago from patch retina, but I have to slide in and out depending on whether I'm reading something or looking at the slides. So I trip or something. So what we're going to talk about today, these are just the stuff I'm not going to have another opportunity to really get through this to you, so it's going to be a fair number of slides that are going to feel pretty good. So we're going to look at just the things that are driving patient engagement. Why is it so hot right now? Why aren't we talking about it? And then just to make things interesting, CMS changed the terminology last October. They're now calling it person involved, not patient and family engagement. That's awkward to use in sentences because a person has a lot of meaning. But by person, what they're trying to convey to us is when someone is in a relationship with you, even as a provider, it's not just the patient relationship, it's the whole family that you're treating basically, and it's aspects of Susan's family as an example. So that, Susan, other support systems, other allied healthcare providers became involved in care. And they weren't just treating her son for that particular condition. We're actually thinking of him as a whole person, his special. So that is what they're trying to get across with that person terminology, not just someone wearing a patient, but a human being in your office. And oh, by the way, you're a human being too. So they need to be, we as patients and families need to be building relationships, taking the constraints on providers, the fact that you can't do everything, that we're going to figure out together how we can best maximize the resources of the family and our communities, work together there. So it's actually a really rich concept, and I think it's going to be awkward to use just grammatically, but that's what. So we're going to talk a little bit more about that. I'm going to just give you a quick whip through the change package coming out of TCPI. So this is stuff that they're expecting to invent and try, and if not invent, borrow, try, improve, refine, evolve, and give you a sense of that structure. And then just look for the opportunities that are emerging already. So I presented a couple weeks ago in Des Moines at Des Moines, for the Iowa chapter of already people in the audience with that started patient family advisory council on our practice. And that's exactly what's going to bring this whole enterprise to life for us. It's going to be what CMS really likes about communities like this, that we bring the real stories and the real challenges and the real problems we're solving forward. That's going to be what's fun about this program. I know there's going to be lots of data, lots of requirements, lots of time, but I do feel, based on the experience I've already had with the organization, this whole kind of alignment with where we brought, there's going to be joy, work, and satisfaction, because we're going to build stronger and healthier communities. So all that is going to kind of weave through talk. I should say such a trip over myself first. Dan, can you get the next slide? Okay, so the whole person, I'm actually wearing a piece of art on my back. So this is a piece of art done by an artist by the name of Regina Holiday, who, if you have a story about patient-family engagement, patient-family partnership, ASI, the person engagement, you can send it to her. She'll paint it for you. This is the story actually of my family. I had two, a mother and a stepfather in 2009, who had both gotten cancer diagnoses a few weeks ago. They had both lost their first spouses. So they had had a good 20 years. They went to high school. Mother and father went to high school in North Dakota, same high school class. He died early from cancer. She married another boy from high school class who said he was bad with her. My mom could never get into remission. He got really bad. He had 3 kids. There were 4 kids on my side. There were lots of family dynamics. We had very different. So really partnered with our healthcare team to get my mom across the goal of the palliative care and to really get her last wishes. We knew what they were, but Bob, her husband, was just so by losing a second wife to cancer that everything kind of tended towards him, and he was just in denial about the fact that my mom was cancer. So we had to basically grab a nurse from the floor of the hospital and say, my mother's not, she's in palliative care now. She and her husband have not really talked about the fact that she's going to die. Can we find 20 minutes of privacy for them in this hospital setting? And some nurses just stepped up right away and did it, and some didn't. So when I described all this to Regina, she came up with a dance. So it's like we were in an elegant dance of people working together, and that's what I'm wearing. Now my job, since she paints this, is I have to wear it when I give talks like this. I'm part of a walking gallery, and it's to raise awareness about the possibilities of this kind of partnership and the real things that we're experiencing. So if you have a story, it takes a long time, huh? That jacket. There's about 400 jackets out there, but she does it for free. She's got now a stable of artists that are kind of working with her, so you might not get one of hers, but it's kind of a cool thing. So And that's also who I am. I'm the whole person here. I'm not just a lawyer from Chicago. I'm a human being. We just made that includes a family. And my family, like a lot of people here. How many people in this room are caregivers for elderly parents? And, how many of you have someone in your family with special needs that has a pretty intense family caregiver relationship? Yeah. So this is us. It is us that, especially in communities like this. We're not going to do videos today because we just tested and it didn't work. And whenever I'm in a room where there's some technology thing that could go wrong, it does go wrong. But they're going to post these slides. Kim Blanton is the kind of patient we want to have. She's a librarian from North Carolina with heart and kidney disease. Was very stubborn. Didn't very passive patient, not a compliant patient. And what she says in this video is, I had a doctor who started listening to me. He gave me little things to do, and when he gave me little things to do, I realized I could do more. And I became a fully engaged and activated patient. So it's a nice little clip that you could use for motivational purposes. She happens to also be African American. And so one of the things that will be coming out of this work, I know our communities are often quite Caucasian, but that's changing too. But it's the diversity. It's part of the what do we need to do to tailor our care to different audiences who may not speak English, who may be new to this country, may not understand their customs. All of that's going to be part of what we work on together over the next few years. So Kim Blanton is a nice story for that. This is just my kind of getting a sense of the audience. These are terms that have come out of work on person and family engagement. And there's three tribes of people that have kind of come together on person and family engagement. There's physicians and practices and patients and families that have been working in the chronic care domain for years and years and years. And this, if you're part of the patient-centered medical home, if you're familiar with that model, that incorporates that sort of chronic disease model. There's people like me. I used to represent doctors in hospitals and malpractice cases, and my journey here has been just kind of twisting and turning. If there was a fork in the road, I would take it. But there's people here who really are focused on error and liability and the sorts of things. Because when you talk to patients and families who have had something go wrong, you get this enormous spirit of how can we help? How can we partner so it doesn't happen to somebody else? And that's kind of the tribe I come from. And then there's a whole group of people that are just really in the ethics of it. The patient at the center, patient's rights. It's my body. I have the right to make decisions about it. And so those three areas, and that's patient-centered care, person family-centered care group who have the principles of patient-family-centered care that they promote. How many of you got that built into your mission statement, or vision statement? Some statement about being person and family-centered. Okay. Patient activation, is that term familiar to people? Okay, so that's very much built into the patient-centered medical home, the chronic disease model. And there's measures for that. There's actually assessment tools that we're going to be able to bring into this work that will help you, assess, how much can my patient handle? What kind of support services does my patient have in his or her home, or his or her church, or his or her neighborhood? So there's measures around that. Patient-centered care, pretty familiar term, but again, that kind of comes from the ethics realm. Person or family engagement, we have to all get used to person and family engagement now. Luckily, the acronym didn't change, so as we get into the nationwide taping events and webinars that you'll be doing, you'll hear PFE is the acronym we use to describe it. Patient satisfaction, we all know what that is. Those are the surveys that we send out to really look at the patient experience. There is some stuff about safety and quality in there, not as much as people like me would like, but it's driving payments as well. So it's an important thing for us to keep care of. Chronic care model. How many of you are familiar with that term? Okay, again, we've got some PCMH people here, I think, or just people who come from either that model or the chronic care model. So that's where the evidence is. In the chronic care model, there is a huge and growing body of evidence that when patients have a job in their own care, they get better results. So there's some buy-in, some responsibility, some learning. They've got a relationship that's probably working there, but it's true for blood thinners, for diabetes, for asthma, for HIV, for any number of things that have been studied in formal studies that show, if we partner effectively, if we really support that partnership, we're going to get better outcomes. And then these are all pieces of the chronic care model, and I've got a slide on that that I'll show you too. But shared decision making, self-management. How much can our patients do on their own? And then support for self-management. How do we support them? How do we figure out what they can do on their own? And then help them figure out the gaps. What's nice about this model is that it doesn't really say all the responsibility is the physician, but it does challenge us to do more, or the practice. It challenges us to do more to figure out what are the barriers that are keeping our patients from getting the kind of outcomes we want them to have and doing the kinds of things that we need them to do as part of the partnership. High reliability organization, safety across the board. Those terms mean, how many people have heard those terms? Okay, so we've heard the terms. So this is kind of in the background of all the work we're doing here is a real shift in thinking in this entire country about how you manage risk. And it used to be that, and this is still true in the legal system. This is kind of where I played and grew up. When something goes wrong in a practice, we point to who's at fault. And we try to find the person who is the most visibly at fault. And as healthcare has gotten more and more complex, we realize that when something doesn't go right, is usually a multi-part breakdown. It's not one person who's incompetent or stupid that day. It's like a chain of things that went wrong that probably go into a lot of different people's realms of responsibility. The big one, the idea of, let's take Wilson, for example, the idea of, okay, we're going to sue you. We're going to make you pay because we want to incentivize you to do this. And that just doesn't work. That's the insurance model, the legal system is built on it. And it just doesn't work because healthcare is much more complicated now. It's not like somebody, does that thing every day. There were circumstances that happened typically. I mean, there are some bad actors that do things, in a bad way, but they're a tiny fraction of a percentage. It's mostly just the system failing. And that's shaping all of it. So part of what we're doing nationally is trying to say, you know what, patients and families are part of the system. So when you think about designing, offices that work better or healthcare systems that work better, we've got to really think about the role of patients and families as this group that has some shared commitment to the results, some shared responsibilities for what's going to happen here. And that's a pretty undeveloped field. I mean, we've kind of been captured by this old model of who's at fault, was it the patient who didn't follow directions or was the doctor who, gave the wrong medication? And that's just not where we can be anymore because that's an old model that's failing. It doesn't. I mean, it's hard to imagine a legal system in this country that creates more fear than ours does. And if fear was really a motivator to fix things, we would have fixed them. And we haven't. I mean, there's news this year that this week on TV that medical error is the third largest cause of death in this country. And it's because we're so complicated. When you talk to the systems people, they, which are primarily engineers, but some of them are also cognitive psychologists, people who understand why human beings make mistakes, which happens, by the way, when we're tired, distracted, or multitasking. So basically every day at work for healthcare providers. Those are the risks of making mistakes. When you look at, when you talk to them, they say there is no other human activity on the face of the earth that is harder to make safe than healthcare. Because of Tom's slide, because every other industry, military, NASA, airlines, police, they standardize. They kind of just say, we're going to standardize, we're going to only have one kind of airplane that this pilot flies. So he doesn't have to figure out which cockpit he's in. We're going to try him at one point. That's standardization. If you think about our role in an airplane as passengers, we don't really bring a lot of risk factors to that equation. We're pretty fungible back there. In healthcare, you've got to constantly customize. You've got to standardize where you can and then constantly customize because every patient is different. And we all bring different risk factors to this equation, and so do the people on your staff. Your doctors, the doctors in your practices are going to have a range of communication skills. Some of them are going to be great communicators. Some of them are going to be poor communicators. How do you support for that? How do you build a team and they may be a great doctor, even though they're a bad communicator. So, or a non-optimal communicator, let's put it that way. So it's just a level of complexity in healthcare that doesn't exist in any other human enterprise, plus a high degree of risk and a high degree of change. And those things all make what we're doing here so important. And it point, when you talk to the engineers, they say, yeah, the other industries are ahead of you. Aviation is way ahead of you. They were investing in teamwork 30 years ago because they realized that even the best people on a team are going to make mistakes someday. And how do we build a team that catches those? But they say the reason that you're behind is because your job is so much more hard. So we are doing really, really important work. Just echoing Tom there. Okay, next slide. Okay, this is the TCPI model. And this is where we're going to be working together. So there's a national program for a bunch of money. You've probably heard about that if you've done any of the webinars so far that has goals. There are drivers, and the drivers have been invented by the TCPI community. They're laid out as part of the program design. But they're basically the things that they say are going to be driving things nationally. Then there's the secondary drivers, and that's how you kind of take the primary drivers and apply them here. And you're going to do that with a series of change concepts. But here's where we're going to be doing the sort of work that kind of goes back upstream. We're going to be figuring out how to do this. Those are the tactics. So we're going to be figuring this out. The PTNs and fans are going to be sharing this stuff. We're going to be testing it. And we're going to be figuring out what works. We're going to be pushing back and refining this all the way along. So it's a very conceptual model, but you're never going to have to really look at it yet. You're just going to have to look at it and realize that for CMS, it's all about these concepts that are driving things, and payment is one, patient engagement is one, sustainability is the other. But here's where the rubber hits the road, and that's going to hit the road in places like we've all talked about it. Next slide, please. So here are the primary drivers. So patient and family-centered care is on this list. And that wouldn't happen 5 years ago. Patient and family-centered care was sort of a nice thing to do, if we have time, or it was a nice thing to think about doing. That we're patient-centered. Here, they're really buying into the fact that, unless we partner effectively with patients, we are not going to reach these goals and produce the kind of health system. I'm frankly shocked that this became as prominent as it did. It came prominent because there were innovators in the room like Tom, honestly, who were saying, this does make a difference. And it's because we're seeing it in the practices that are really doing it. We're going to be able to bring some of those best practices forward, I think, and we're going to find some that you're already doing that we don't know about yet. That's why I kind of piloted Susan here. It's like I sit down, I've met Susan many, many times. I knew you had children with some special needs, but I've never really heard your journey as in the way you're partnering and getting your providers to partner with you and wrap, their care around the needs of your family. That's a fantastic model. So data-driven improvement. You're going to hear more about that from other people, not from me. Although we are going to develop metrics for measuring patient engagement. I'm going to share with you some of the metrics that we've already measured in the Partnership for Patients. For the very first time ever, that CMS began measuring, okay, what are you doing in patient value? What structures are you building to kind of bring that voice of the patient into your work so you can get them as a partner in their own care, but also get them to give you some feedback about your practice, how you design, how your plant is designed, your office is designed, your processes are designed. All of that is coming into a framework that we're going to go through. And then how do you make it all? What is this paid for? What is this isn't paid for? What kinds of skill building do you need to develop? What kinds of structures? And those are the primary drivers. Makes sense. Still 10,000. And then secondary drivers are this is just a thought model about where it is that we can move forward here. And these are what they're giving you to sort of say, make this work. And that's where the tactics and the stuff. That's what we're going to be doing. Okay, next slide, please. Okay, I'm going to now do just sort of a series about really what is driving this. This is Susan Dempster. She was the editor of Health Affairs, Big Health Policy Journal in 2013. They did a dedicated issue to patient and family engagement. Before we were calling it person and family engagement, to sort of say, okay, there's all these different tribes that are happening, all this energy. We have some evidence but not a lot of evidence. What is this? And she makes this point. There's this resource that is right here. Patients and families who care deeply about their own care. It's just we haven't figured out how to work with it. My heaven, that's terrific. If you think about the Blockbuster drug, and think about the medication regimen of your patients, or some of your family members. You cannot have good compliance with medication unless your patient really is bought mean, I couldn't figure out how to take 4 pills a day for myself on schedule with food or without food. And there's people who are just, 20 pills or 19 pills. It's really complicated. We've got to have better processes to do that. That's just one example of how this is an area where I think we have huge potential to learn from patients and families that are brain disease. That will be another signature part of this campaign, Tom, that you didn't really mention, but the whole famous approach, this is Dennis Wagner, Paul McGann, those people, it's build on what works. Don't focus on the barriers or the negatives. Focus on what you can do today. Focus on what you tried that's worked. We're going to build on that. They call it net forward energy. But we know we can find patients and families that we can bring forward through this community, this nationwide community of people working in TCPI that are going to say, yeah, here's what we're doing. Here's how we figure out how to take our work. Or what to do when we detail and we're supposed to detail. Okay, so that's so this whole issue kind of put it on the map. It was emerging, but this is like a tipping point. This journal of health affairs in 2013 came out right in the middle of patients, right at the beginning of partnership with patients, and it just kind of government contract. There's a whole lot of money on patients. People trying to figure out what to do, and we'll be able to take advantage. Next slide. One of the things they do is my group, which is a very small group out of Chicago. I'm the head of a consulting group, and I find people who've had an experience in the healthcare, either with a harm event or managing a chronic patient, who also have other skills, like communication skills or consulting skills. And I bring them into my team, and we go, okay, we're going to create this full person environment when we go out and work with groups like the Compass PTN. We're going to bring that patient voice into the room because they are us. If not yet, we will be someday. Okay, so flash forward from health affairs, we have now CMS in 2015 saying, okay, we're going to build patient family engagement into our overall quality strategy. So the alignment that's happening around payments is part of an overall strategy that certainly is grounded in Obamacare, but now being built out in macro and other things, all being driven by a central strategy. And patient family engagement has been built into it. So it's not going away. This is the way it's coming over everything we do. And, as soon as CMS starts articulating this, we're going to see the other payers doing more and more. They're going to take this from, this is going to be a nationwide strategy. We're waiting for an action plan. A different consultant is developing that. It's going through who knows what layers of review at CMS. All we know is it's going to be called person and family engagement. It's going to be and the action plan is supposed to be out in February, and it's May. So we're still waiting for it. But again, it's not right now. Next slide, please. So this is just kind of a breakdown of some of the places where it is growing. So it's growing. I said there was money here. The money's coming from different places. It doesn't really capture plans because this is just sort of the DFE stuff that's happening in the federal partnership with patients. I'll walk you through the metrics, the roadmap that they're using there very quickly. That is kind of grounding. We're going to be looking at how we apply that to physician practices. Most of the work in patient engagement is written by the journal, Blockbuster evidence at the hospital base. Also, the opportunity for patient family partnering is going to be non-hospital based. So again, I think we're going to really interesting work ahead of us because we're going to get to fill out the gaps in this. Already covered the TFE strategy. HRQ, Agency of Healthcare Research and Quality, they fund research in this area, and they're funding a bunch of toolkits. They're going to be coming online as we work to look at what tools we can use in our primary care offices, but they also have a real interest in education after the event, preventing lawsuits. They've got a very patient safety, litigation, prevention focus. So within the next 3 weeks, they're going to produce a major toolkit that we were involved in Chicago that basically encourages people to communicate really, really quickly after an adverse event. Will show with evidence that it actually will reduce survivability. So it's counterintuitive for lawyers. We tend to think you shouldn't say anything until you know exactly what happened, because everything you say could be used against the law. what this model is essentially going to say is, yeah, but if you wait till your investigation's over, your patients think you're covering up or you're manipulating or you're having user problems. You've got an opportunity to build trust here. It's going to be the worst day of your life. You go in and say, oh, I'm sorry, I'm giving you my medication. But go do it because your patient is prepared. It's going to make your cases go away or settle faster. You're going to have a lot less. So there's things like that that are in the mill that are going to be coming online as we work together for the next 4 years. I'm going to actually go through the guides for primary care because that's going to be really, really relevant to our work a little bit more. This slide is what's happening. And then Tom already mentioned the QA and QAO. They've always had sort of a patient safety, patient engagement piece to their scopes of work that it's never been emphasized. It's always been, fraud and financial accountability, and so that's the center ring for them. But they're now every scope of work is more patient family engagement, and so they're a player. We're going to figure out. We don't have to figure out how to work with them. I guess we are doing. Intelligent and another QIO in the room, but this is an emphasis for them as well. We're doing an interesting project with them on medication use, where we're actually surfacing stories of patients that are partnering unwell to manage huge medication burden. And we're going to just work on those stories. Mine those to figure out what it is that's working and see how replicable they are. That will be coming within the next year. A lot of stuff is happening with feed our mills as we go forward. Next slide, please. By the way, I feel like I'm just talking, yammering here, a lawyer in front of the room. Does anyone have any questions so far, any comments or feedback? Please raise your hand or do I put you to sleep? I know I'm before lunch. No, you're lucky. I usually have that problem after lunch. Okay, so what's driving this is where we're going. So CMS is going to want to see patients playing more of a robust, activated role as providers in their own care. They're going to want to see you bringing patient voice into the way you sign practice. And then, they're already bringing patients and families into setting policy. We have patients and families on almost every that CMS is doing. And these frameworks are all created by people in Washington, live and breathe, this committee meeting or that committee meeting. So there's a lot of work there that is going to be, I don't want to say less relevant to us, but less immediate for us about how we get them involved in policy making. But there's a lot of patients who want to do that. And they testify, they join, their patients families everywhere. So there's a lot of pathways to it. But it's really one and two here. Provider to the point of care and bring that patient voice and feedback into our own practice. Next slide. I think we've pretty much covered this. These are the tribes I talked about before. So it's the ethics tribe, the chronic disease tribe, and the people that are really going, okay, there's responsibility here when things go wrong. Just don't just go on do a simple model of who's at fault. Just looking at the systemic risk there. Next slide, please. Okay, so you haven't had Systems 101. I'm going to give you Systems 101 right here. There's like thousands and thousands of articles here, but this comes out of a human factors group. The human factors is the science and engineering that looks at how the human beings in the system and organization and the way the organization is organized impact. This is their basic model. This is the system. It's this circle here, and it includes your plants, the way you're organized, so your bylaws, your corporate structure, and the technology you've got, the work that you do, and right in the middle is person. And this is an old one. And when they talk about people, they were primarily talking about providers. Providers being the ones who run this whole system, and therefore are at the center and are all the problem solvers. Most of the literature in the system doesn't really realize that persons here in good patient center. So this model is very, very applicable for us, but there's very little discussion historically. Because these are models that are created by engineers. Engineers get really, really nervous about the variability in patients and families. You can tell an employee what to do. You don't know what a patient or family is going to do. So these models were created in kind of the old way of thinking. We're going to do this for our patients, not with them. We know that doesn't work. basically, this is the work system. We do our work through processes. We have outcomes, and then these are the processes when we see them fail, feedback, we make changes, or the outcomes feedback. This comes from a group of human factors people at the University of Wisconsin. Pascal Carrion is the main person, but it's just kind of a little bit of orientation for you to think about what is driving the change here. Next slide, please, is the simpler systems model. Maybe you've seen the Swiss cheese model. This came out of the world's sort of premier expert on human error. His name is James Reason, a cognitive psychologist from Great Britain. But he said, these are our defenses. The Swiss cheese are all the things that we do to try to prevent harm in our systems. And when a harm event actually penetrates our defenses, it's because it's all that we haven't. We call them latent failures. But it's something that you don't really predict until you're in the middle of it, and then it has to line up with the holes in all of your other defenses to produce an event. Because we have a lot of prevention that we do in our work. We try to catch people on time, make sure that we do medication reconciliation when they're late. But we may not know about the fact that they've got another doctor who's something different from them. That would be a hole in Swiss cheese. We don't know that until it happens, and oh my God, we've got a problem solved. And that's why people are so important, because no matter what you set up, your defenses is always going to be these holes in Swiss cheese, and people have to problem solve. And that's what people are really good at. And if we're partnering and have relationships with our patients and families who can problem solve better, we can fill some of those holes in Swiss cheese. Next slide. This is a nice video about this whole thing that I just talked to you about. It was produced by the Gordon and Betty Moore Foundation. They have stepped up to be the biggest philanthropic funder of patient and family engagement in the entire world. They fund the World Health Organization, they fund CMS, they fund good medicine. And they've got a whole nice little video here that would also be a great orientation piece for your practices. You and I saw this at the HRQ meeting in March. But basically laying out that patient-family engagement is not just the point of care, it's going to be all of these different levels, including design and including getting out of the hospital and moving into the neighborhoods where patient and provider interaction really happens much. Sorry, I just leave you with that teaser. Here is the roadmap that came out of, here's the graphic that came out of that roadmap. I'm going to just quickly walk you through this for again, orientation. The green level is direct care. This is where your patients are partnering with you at direct care. There's three domains: consultation, involvement, and partnership. So at the consultation level, you're giving them information about their at the involvement level, you're listening to them feedback, the circumstances, the things that they say, really telling you where they are as a patient. So the patient activation stuff is there. A lot of the techniques that you might be using in your office already, where you would have a patient back to you, we repeat back to me what you just heard me say before you leave, so I know that you understand that your Ambien is different from your other medications. Sounds very similar, but you take your Ambien at night when you go to sleep, you take the other one in the morning when you have chronic infection. So that's the involvement level, and then shared decision making is really the process that I think is core to your practices. Is, okay, this is not my decision. We make this together. How do we do that well? So the Choosing Wisely campaign has a bunch of tools for how you do that well. This is sort of basic practice. At the red level, this is the organizational level. So the consultation domain is serving patients, so patient satisfaction tells what you think about us. The involvement level is what do we do? What structure do we have in our organization to really move beyond the survey to bring that voice in, problem solving, feedback. And for hospitals, the attention CMS is really shining a light on is the patient and family advisory council. We thought that would be a hard thing, honestly, for smaller practices to do, because it does take some time. But it's low tech, it doesn't take a lot of time to do it. You've got benefits in your structures because you know your patients. Hospitals patients go. You know people who probably are thoughtful and see beyond their own condition, give you some good ideas who are situations where. So I'm going to show you, I'm not going to run through it, but we're surprised by the number of patient family practices, family primary care practices especially, that have built councils. I think we're going to, has anybody here built a council? where you actually have your patients coming once a month that do, for, cookies and coffee and talk to them. Okay, so we're going to have several models. If it's something you were interested in, it's something that I think CMS would get. That, oh yeah, that's patient engagement. We're happy to see that happening at practice level. Practices who have done it almost routinely say, you know what, I sometimes hear the worst things. I don't know whether I want to hear it, but I know it's loud here because it's honest to tell me things that I don't think. Just to give you one example, there's a clip here that I'm not going to be able to show you, but you're going to be able to look at it later. It's going to be on the website from Dr. Mary Reeves, who's in small practice, pre-physician practice in California. She said, I was a skeptic. I thought this was just fluff. I didn't really think it was, it's going to be important. We decided to try it because it was easy to do. We invited our patients in. The first thing they told us is that our brand new waiting room that we had just redesigned to be HIPAA compliant, so that our patients in the waiting room couldn't hear what we were talking about behind the wall. That, oh, by the way, created a wall. So we now have a little window that we sit behind. The patients can't see it. They don't feel like we can see them. It was and we hadn't even seen that or realized it until we brought them in for coffee and cookies. And so, we really hate the waiting room. Things that it didn't apply. And from there, they went on to things like fall. What do you worry about falling? What can we tell you about this? So it is a simpler thing to do. I'm going to give you 8 steps here, and there's something coming actually out of the AMA FAN for how to build one of these in 8 quick steps that I just cribbed from to the slide that you're going to see in a little bit. But this gives you a sense of kind of how that applies. This framework, I think, was thought of by people who are hospital-based, especially when it gets to the policy-making level. I mean, this is policy-making in Washington, but it's the premier framework out there, and now you've been oriented to it and another to see that's the number of different topics. And that's in the same issue of health affairs where it's sort of been throughout the editorial. Okay, any questions about this? Okay. So CMS, when they talk about systems, they talk about systems across the board. Tom and I heard a lot about this for those of you who were involved in hospital engagement reports. How many of you were involved? We had several webinars about safety across the board. When they say, look, we want you to work on these goals, they're essentially saying, we want you to build a system, because you're only going to be able to produce these goals if you systematize what you're doing, and they're calling it safety across the board. This could change. I don't think this is in a couple white papers. It's actually even hard to find their website, but there's some champions that for this. If we build systems, if we have composite safety scoring, so we're looking at our scoring, how we're doing overall, and sort of an overall report card, we're going to be able to find the patients that we're failing. They're going to come out. So this is the population-based measurement, the looking at your diversity, looking at people who have disparate outcomes, to be able to focus on them, be able to improve clinical performance overall by not really thinking that people are average, but breaking down our data with looking at how it tells us where the opportunities are, and we're going to create efficiency. The outcomes are going to be satisfaction, health status, community, financial performance. So it's very aligned with what we're talking about here. I'm showing it to you today because it was common partnership information. I wouldn't be surprised if it's going to emerge again. And this is basically their systems approach. Okay, next slide, please. So change tactics is where it's really going to be about. That's going to be what we're doing on the ground. But we're going to be borrowing, trying, inventing, and pushing back upstream. And that's what we're going to have, I think, really useful. Actionable specific, they're going to be, you're going to be customizing them to your own practices. And again, I mean, I think the Midwest brings a lot to it. We do live in places where I think there is more sense of responsibility, self-reliance, stepping up, being part of teams that produce results together. Okay, next slide, please. Partnership for patients, I'm going to very quickly run you through the metrics that we use there on patient identification, because I think they are going to translate. My group is involved in the metrics discussion. We've made recommendations, but they are pending. So we're seeing that probably pending to see what the CMS strategy. Kind of a black box for me now. We made them 6 weeks ago. We haven't got So our best estimate is looking at what they did in Partnership for Patients. So this is just some background on Partnership for Patients. It's a big campaign, very hospital focused, with very clear goals, and then some projected outcomes that they wanted to reach. $500 million spent there. TCPI was spending $700 million with taxpayer dollars, right? Okay, next slide, please. Yeah. So, and these, we measured 5 things. So think about those frameworks I just showed you. We didn't measure anything at the policy level, and the organizational design level. This is going to be hard to reach, but PFE measure 1 was discharge planning. Use some kind of checklist, part of your procedure for discharging patients, where you don't forget them. Use that checklist methodology and you help them not forget them. There's a CMS model for this. If the metric was, if you could use any checklist, we just want to know that you're. It was targeted to elective surgery because sometimes you just have fewer options. Something that's not elective. That was the first point. For the second one, this was, I think, we can say now it was transformational. Do you do your shift changes or your huddle at the bedside where the patient can be part of the conversation? For some places, this was being done. It felt natural. For other places, there was a lot of nursing homes. Taking the time, they're not going to understand a lot, and we saw a huge change in attitude as CMS pushed this, saying this is a simple thing for any hospital to do. No new technology. We just want you to have your conversation with the patient instead of about the patient. Because, oh, by the way, that's one of the things patients complain about. It's not, you know, hearing the nurses talk outside their door without involving them. The middle two, the 3 and 4, were at the sort of middle of the organization. One is that, is there a person in your organization who has patient engagement as their job or department? If you have some functioning organization, there's a person whose job is to think about what you're doing here with develop strategy. And so often the QI department, the state department, sometimes in a patient advocacy department, but do you have someone there? Again, kind of a loose definition, you could have it anywhere. Fourth is, do you have a patient family advisory? You have some kind of a structure where you're actually bringing that patient family voice in a real way. And, you didn't have to build a new committee. You could assign bring patients onto an existing committee. So a lot of hospitals have done is either built a new group that meets usually once a month, maybe once a quarter, but reports up to like a safety committee or board or for a C-suite. And that is probably the one that's pushed the patients. Let's build that infrastructure so that you've got some way to really bring that forward. Again, there were hospitals, and we measured every hospital in the state had it. I think every hospital had a patient advisory committee because it had just been part of their culture in the state. Academic hospitals were probably one of the biggest changes. Those days of the world. We have complicated patients. What do they know about their condition? Well, maybe more than you realize, and maybe they don't know about their condition. They know about how you treat them. So that is, we made progress. So the black bars progress we made over by the end of the first phase of partnership patients, which was the end of 2014. But there's more progress to go, obviously. And the last one was, I think, probably one of the most inspired. If you really think about culture change and transformation change and picking up the model, they started asking hospitals, how many do you have people who identify primarily as patient or family in your board of directors? Are you bringing them in at your board level? Again, for some community hospitals, this was normal. But for other places, it's like, oh my God, we're not going to bring a patient on the board. We talk about these things there. And so it really fit well into their whole kind of transparency mission and everything. And you'll see that that's the one that we have the complete number of hospitals complying. But this is one where I think they're going to really push going forward is bring that voice of your user of care, your partner, your co-producer, into the dialogue at the very highest level of your organization, where this is it. And, for the hospitals that have done this, we get glowing reports about, oh my God, we are hearing things get filtered out as data moves up to us, or as reports move up to us, because it's the real patient experience. You can see culture change happening when someone comes in with a real story, and they're not putting a picture, they're just saying, I'm here because I want to help happen. And that happens. We create that capacity. So, of all the questions the team has asked me about, this stuff. Marty, how many hospitals are doing this? What more can we do? There's some real interest. How that applies to your practice structure, I don't know. I think it's feedback. I can see physician practices doing that. I don't know board structures here or how it works. Yeah.
Two of those are must-have in patient-centered medical.
Yeah. So what's interesting too, and I didn't know this. I'm sorry, what's your name?
Karen.
Karen. I didn't know this honestly until Tom and I had a dialogue that there was all this work around patient-family engagement in the patient-centered medical home. So I went back and looked at that model, and you can see that patient-centered medical home having informed these metrics in a way that I didn't even really realize, because I was from the liability tribe. I wasn't from the chronic disease tribe. But yeah, so it's interesting. These came up over time.
The huddle
The huddle?
and the patients being on the board, or they're on the quality improvement. They can be on the board, but must have for patient engagement on the quality improvement.
Yep. And that's great.
That's really important. We're going to talk about that later. The PFA2 and PFA5,
Yep.
those two are actually embedded within the patient model.
And they're must.
Yeah.
So,
And then F2HCs also have requirements that their governing boards include a huge percentage of community members. So I think that's another kind of building block to build on. Next slide, please. Okay, so what do we get from that kind of patient-family engagement? This is something I can't say is a correlation, but this is the kind of data that is intriguing CMS and pushing forward. This is a report from Minnesota County looking at comparing their outcomes on the 10 hospital-acquired conditions that the Partnership for Patients was really focused on, including readmission, reduction of 30-day readmission, and then this is a comparison of hospitals that have saying yes to 4 or more of the PFD metrics versus those that were saying yes to 3 or less. And the blue line is yes to 4 or 5 of the PFD metrics. They were driving down their hospital-acquired conditions at a faster rate and to a much bigger degree. Now, I think this is confounding because I don't think PFD is fully responsible for this. I mean, hospitals that are doing PFD probably also have inspired leadership and a lot of things for their staff. So it does depict that PFD is part of a bundle of things that might be making a difference. So as CMS goes forward and looking at the data that we produce or we report, they're going to be looking for patterns like this and trying to figure out what. I think it's going to come down to leadership, honestly. Leadership bringing this voice in and harvesting some benefit from this as part of the bundle. But this data is, I'm hearing several of the HINs. We got this data from 2 HINs that didn't have to report it. They just did it voluntarily. I know many other HINs did it too. So this is a pretty consistent. Again, a lot of it has to do with just an organization that has made patient and family engagement a part of a bigger structure that really is focusing on improving the patient. But still, it's notable. Next slide, please. So what we learned is that when you bring patients and families in, you get their stories, but you also get contributions to your strategies, to your tactics. We also have sort of increased the buzz out there in communities that, oh my gosh, the healthcare system is bringing that patient voice in. And that's, I'm hearing that from the networks that I hang out with, which are patient families who are networking on the web and on Facebook and talking about infection or whatever. There's a heightened awareness that things are changing and CMS is driving it. We can use that. We can find people and give them a chance to tell stories and contribute to our work in a way that we didn't before. I'm really happy to say that. I mentioned the culture change piece. We have extraordinary stories that we can share. You probably have them too. A patient comes in and has a conversation with somebody, a physician making a difference and things change. Those can be very dramatic. They can connect, as Tom says, beginning the head and the heart. This could be our family. This could be someone I love that's here. And I know we've got the other rooms because I talked to Susan last night. I feel this way. We're here to make things better for the people that we love, who are in it as well. And that's what I really mean by culture change. So when we get that voice at the head of your organization, talking to the doctor, talking to the board, the magic kind of happens. So, and if we can flesh out examples of that from So that's kind of the shift. This is a big shift in patient-family engagement. We moved from thinking this was a nice thing to do to go, okay, here's where we think it's actually making a difference with actually being part of training. So that's the lesson so far in this presentation. Next slide, please. Okay, so here's the patient-centered medical home. This is just a model I grabbed, honestly, after my last conversation with Tom about this, but you see that whole person orientation, safety and quality, these are just 4 components that as we go forward, the patient-family engagement piece is going to be driving parts of this. Next slide, please. I'm going to go through this very quickly because Tom and others are going to work through this with you later, and we have some experts. But this is Tom Bodenheim. Same thing with Tom Bodenheim. He's out of California, one of the big thinkers about the patient-centered medical home. You'll see the basic building blocks of creating an organization that really is focused on partnering and getting the best results is that patient-team partnership step 5. But I'll tell you, when you look at the literature here, it's almost all pointed there. There's a lot in patient-centered medical home about bringing people in really at that board level or at in a feedback way. Next slide, please. So when I was looking at the slides, I found this, and you can see the patient-centered medical home models evolving. For the University of Massachusetts, and if you look right here, it's patient involvement and transformation. Not just discipline care, but we're going to bring them in, tell us how we're doing, to give us their point of view, to put them on our board of directors. I don't know what's all in here, but you can see the model morphing. Look to the literature. Again, those are going to be tools that we're going to have to make sense of, but it's a dynamic model. Next slide, please. That's pretty much as I know about the patient-centered medical home, but this model comes from chronic disease. This has been embraced by the patient-centered medical home. This is called the chronic care model, and I love this model because it just depicts exactly what we have to be doing. You'll see that the health system here, which includes physician practices, is part of the overall community. So it's not distinct, it kind of almost blends in to the overall community. So community resources are part of what we have at our disposal. We're trying to make our community safer. It's not just all about the physician's office having all the responsibility. It's about being a part of this ecosystem, basically. Within the physician's office, you see the emphasis on decision support, certainly clinical management, design of care, but decision support and self-management support. So as we bring our patients in as partners, our job is not necessarily to solve all their problems, because we can't do that. Right? So we can help them figure out where their barriers are, what's getting in the way. Is it something as simple as transportation that we might be able to, or make a recommendation? Does your church have a transportation service? We were talking yesterday about Uber. There are places now that are beginning to use Uber to get patients back and forth to their doctor's appointments. In Chicago, where I live, where you have, heightened risk every week of being shot on the street, we know that in bad neighborhoods, people don't go out because they're afraid. And so they stick at home. The isolation that we're creating in certain neighborhoods may be able to fix. So that's just one example of the kind of self-management support that is possible. And then, of course, what you do is create the partnership down here. Proactive practice team is asking the right questions, helping you figure out, okay, well, what about your circumstances, patient, do I have to know about to make the best recommendations for you, make you the best partner? Bringing the patients along with small steps that they can do and build on those to really understand, okay, here's what I'm willing to do, here's what I'm motivated to do, here's what I'm not motivated to do, and building a plan around wherever that patient is, try and get to the next level. Again, in the context of an overall community. So this is, I think, a really nice model with a terrific amount of literature. There's a lot of practical tools about things for office practices to motivate patients, templates for questions you can ask. A real distinction between also the patient and the family caregiver. And in the literature, you often see those two groups kind of lumped together, patient and family. You see that in our acronym, person and family. But when you think about it from a real life point of view, our jobs as caregivers for patients are really different jobs. We've got a lot more responsibility, and depending on the condition of the person that we're caring for. We've got to think about HIPAA, we've got to think about, we may be the one managing the medication list. So really distinguishing between those two audiences. And there are whole organizations that are focused just on the caregiver. How do we support the caregiver? How do we engage the caregiver? What if there's no family? That's increasingly the situation in our country right now. People living in isolation with no family. So what is the family look like? And all this stuff is a terrific number of tools. Many of them coming out of the patient center mental home that we're going to be able to that happen. So, Tom, this model, I think, is part of your slides too, right? Right. Yeah. This is where I connected it with your talk. It's like, oh, I use that model. I didn't realize it was in the patient-centered mental home. Next slide, please. How are we doing for time? I should be wrapping up in about 15 minutes. Or...
Perfect.
Okay, good. Okay, so here's just a little bit more on that HRQ guide for patient and family engagement, because these are going to be interventions that are coming down the pipe. Tom is on the technical expert panel. We're going to be producing pieces of this quickly, and other pieces kind of over the course of the next year and a half. So their focus is on primary care settings. Next slide, please. It's this place of patient safety. So how do we improve outcomes, prevent avoidable harm by engaging persons and families? Although over at HRQ, there's so-called patient stuff. They haven't picked up on the stimulus and go down. And they focus on primary care. And they start by looking at all the research that they can find in three domains and trying to find this sweet spot. What do we know that works, that we can prove in the other? Next slide, please. What they found is not a lot of proof, honestly, that was clear in the evidence, but they found these four areas that they're going to really focus on. One is the breakdown in communication. And this can be communication between an office and a patient family. It can also be communication among staff or amongst the community resources that we know have to be part of this. Medication management. Medication management looms large in the entire field. And we're fortunate because Tom is a recognized leader in the whole transformation community for saying, you know what, if we can manage medication, we can prevent a whole lot of other things going wrong, including readmission, including some of the infections, the pneumonia. It just is a part of virtually every sort of thing that is on all the lists of things that are preventable. And I don't see how you can possibly do medication without the patient being a partner. So this, I think, is the real sweet spot for patient engagement. Could be where we put a lot of our energy. Patients and families know about infection too, because they hear about it on the news. I mean, Consumer Reports did a really, really stellar job about 6 or 7 years ago about really highlighting in the public press infection. And so I think that's another area where we can work, but the role of patients and families taking medication is just so much more robust. We have to engage in the partners. But I think infection and medication will be probably the two main things that we're going to find. At least some sharing of the mental model as we talk to people. Yeah, there's risks here. Here's why we have to be partnering, because we want to prevent this bad stuff. They won't be shocked. They were shocked. MRSA, oh my God, even there's MRSA. And now there's a sepsis story, and it's pretty much pretty too. So it's out there. Diagnosis and treatment. This is a huge policy issue in Washington right now. Medicine says there is so much trouble right now with making the right diagnosis. Even when we do make the right diagnosis, getting it to the right places, getting it to the patient, getting it from the specialist back to the primary care doc. There's just a lot of communication breakdowns in how we transmit our tests and our labs around diagnostics. So that will be like chart up the literature is a huge gap, and then just fragmentation. So polypharmacy, the fact that your patient might be a doctor, might be getting information over the net. You may not hear. You can be coordinating. This is where the patients are going to think it's really built in. So there's got to be a place, a coordination place for care. So in many places it doesn't exist. So those are the four things that came out of HRQ that said, okay, we're gonna tackle these. And what's nice about HRQ, next slide, 10, is we'll go past. This is just more saying, this is where we're going to kind of focus on this relationship in this guide. And the guide, I mean, it's not going to be a tone, or it probably will be a comment, but it's going to come out in pieces of distinct toolkits that we can use. But they're going to really focus on the relationship between practice staff, patient, and you're going to really try to focus on I think the practice staff is totally less utilized now. And I realize I'm talking to an audience of practice. So they, I know there's a lot of practice staff in it. So what do they say about you when you leave? Are you part of that equation so that you can actually play that role? This is what's really happening. I think that does happen in a lot of practice. See the doctor for 7 minutes or whatever he or she has for us. We then go to the labs. We don't really know how it all gets put together. So, and then the conversations that you have with your patient, he or she is leaving, is also who's having that, is it coordinated, what can we do to better coordinate? So these are the 4 things they're going to work on. These were other kind of things that they thought were important, but they were only funded for. So we went through this whole kind of process of saying what are the top 4 that would be the most useful to the field right now. And first one is, when they say patient engagement and care, there are a ton of materials that already exist that we know patients over. Website to go to. Why don't we use them? We must not be supporting sufficiently if they're finding them or they're being able to use them. So what can we do to kind of make things easier, whether it's more pictures, less words, ensure that we get at the point of care. I don't know if there's going to be some goals that I clearly think, okay, we've got to make sense of the fact that we're giving them information. Second is teach back. And this is just a simple technique where you actually, how many use teach back your patient? You ask your patient to teach back to you what they heard so that you have a good sense that they have a shared model of their care plan and safety. That'll be the first one that comes out because there's a lot of material there. They're going to be looking at the best tools, just packaging something that will be, I think, a nice thing for us to use in care. Third is warm handoff. And this gets to that relationship and that conversation I was talking about in the office where you're not just being handed off from one person to another, but there's a coordination between all the different people involved in the office with the patient at the being part of the conversation. And I think I don't have my head around exactly what this tool is going to look like, but a lot of it is going to have to do with the fact that much of the way we track information about patients now is electronic, and yet in the relationship itself. So that coordination between physician, office staff, and patient is going to be the focus of this. I don't know if you have in the warm handoffs. Yeah. You want to add something to this? I think we'll get it more than
the kind of concept of warm handoffs starts in the hospital where the idea is that we have patients being cared in one venue and pass them off to the venue. So I tell you all about like transfer of care rates in front of Kevin, and then we kind of get Kevin trying to make sure it's a handoff is done. Imagine if we start doing that in the provider community, and it doesn't mean necessarily primary care to specialty referrals. It could be just within the clinic, back and forth, bringing the patient into the discussion. And it kind of actually the way I look at the warm handoffs piece is back to that bucket list slide of the different phases of the provider community inviting the patient into our discussions. There's another, we'll talk about it, but the provider, it's interesting. Most of the time when we talk about patient and family engagement, we all go, yeah, I get that. And it's like, oh yeah. And either I do that or this is fluffy and I have time for it. And there's actually a whole kind of a segment, like a series of phases we have to go through to truly engage the patients. And I'm personally, when I look at that warm handoffs piece, we need to take those phases and integrate those in, because the warm handoffs are like phase 3 and 4, where, okay, the patient, I've actually let them in, but now I'm engaging them in decision making. So, okay, we'll come back to that. I've got that slide that will be in my deck. So, okay, and the last one is medication use. This is probably the most surprising thing from the literature review. There are so many tools out there to help patients and families manage medication. So this is a medication reconciliation process you have in place, the list stuff, and there was no evidence that they were they stopped counting after 40 different studies with 40 different lists. And so there, again, is something I really, this to the first one. You put stuff out there where you really don't know what to, you don't know how effectively it is. It really fits the needs of patients and families. So what can we do to support, going back to that ecosystem model, frontier model, support the use of these tools if they exist? And which ones are the best tools, but then how do we support it? Are we asking the right questions? Do we know how to use it? Are we talking to
sometimes lie with it, because, you know, we're ashamed. You know, we go in and say, oh yeah, I've got a family member at home. And what we don't say is, but, you know, sicker than I am. I'm taking care of him. Or he's my, you know, adult son living in the basement with a weed habit. You know, that doesn't come out of the conversation. And so you end up needing to really probe a little bit more about what's really happening. Or they don't say, I'm afraid to come, because they don't really know that it's appropriate to talk about it with the doctor. So all of that stuff, I think, is going to go into these support tools for you out there. Patient family, this is going to be, there is a lot of work going on here, not at HRQ. And part of the reason they did that is they've already invested a lot in patient family advisory councils at the hospital level and kind of the regional level. So they thought, you know what, people could already adapt what we've done. We're not going to this limited bucket of dollars to develop their same thing with shared decision making. They thought it was really, really important, but they know tools exist out there. Okay, Dan, I'm going to just run through the rest of my slides to these here. Next slide. This is the QIA work. QIA work is focusing on medication. They, you'll recall that physician staff patient relationship here. The one that they're going to focus on is not the staff, so that's one corner of the relationship. What's happening in the community? So what community resources can we use to better assess our patients and then support them? Pharmacy being a big part of it, patient and family, and then payer. The payer supporting this work. When we talk about sustainability, we're going to hire a different staff person to do some of this care coordination and caring. Or, you know, if we're going to have to hire somebody to go out and coordinate with the community organization to make sure that, you know, a patient we know is vulnerable, is at home doing what we think they're doing, what they said they were going to be doing, who's going to pay for that? We have to get the care community. We've got seen them, but we're going to be looking to try to figure out whether we can get other payers involved. Next slide, please. And what's cool about this project is we're going to build this around patient stories. We're finding stories of patients that are successful in medication. We're gathering those. We're going to use those to motivate and to learn. So if Tom's got a father, Morgan, who lives alone in Iowa. Two kids, right? With son and daughter who are helping him do it. But what does the partnership look like there? Can we replicate that elsewhere? That's the kind of story that we're going to be building here. We've already got people here. Actually, Bruce and Connie are an Iowa couple. He's a pastor. She's on overtime medication. Keeps track of it on a spreadsheet. You know, I don't know that it's the best way, but we're going to find these stories of partnerships that are going to challenge us to think what we could do better to support people like that. Next slide, please. There's going to be guides for all of the different players. So each of those four corners in that pyramid I showed you, we're going to put together a toolkit. And we're going to just look at how useful they are over the course of this year. But if they are useful, it's an intelligent project actually. For subcontracting intelligence, we have a plan to get this really well funded and spread next year throughout a much bigger community. So we're in a sort of a soft pilot now. Next slide, please. This is Mary Reeves. This is the person from Colorado talking about how she, you don't even have to be a believer in PFAS to give it a try and how surprised you. So this is a nice little clip I just took with my iPhone at a TCPI meeting. We can do that here too. Get stories, we can take them, but watch this if you get a chance, because she makes it seem like it's a really simple thing. And it is a really simple thing, and she learned a lot. She describes it as one of the best things that they did. Had no expectations that it was going to be great. Next slide, please. These are the 8 steps for starting a PFAS. One of the things you have to do is figure out where you're going to do it. You're going to do it at your own physician practice, and I think there's a lot to be said for that because your physicians are already, your patients are already invested. That's an advantage that a lot of hospitals don't have. You really have some chronically ill patients that are very difficult to apply from the hospital. Your system, they already have a strategy for bringing patient voice in that you can build on. And some people are building these along service lines. So heart disease, diabetes. I know I'm now finding feedbacks that are built completely around the portal. You know, let's have a feedback to help us figure out how to get the patients through the portal. So there's a lot of different options, and these 8 steps are taken from one of the SAM, the American Medical Association, published this within about a month. 8 good steps to building the structure in your practice. Next slide, please. My role, the role that we have in this kind of just watch what's happening with, so I'm built into your structure, Tom. I am your faculty, so I'm going to be here working with you, and that's, I mean, I'm only working with one other PTN. But at the federal level, we're going to be looking at what all the PTNs are doing and just trying to manage this. What's working, what's not working, what's through the cracks, of stuff that's out there that just isn't working. It's too hospital-based, it's too old, it's whatever, and then just align between others and people. So I'm thrilled to be working with you, but I also kind of get to see this at a national level, and it'll help me focus more effectively. Yeah, these are, so Natasha Washington, who you have met, my colleague, she's going to be doing some of these talks with the different PTN. She's our national person. She is also college with UT, so she's passionate about this. She thinks that his diagnosis wouldn't have been made because he was black at a certain age in a certain way. If she hadn't gotten an autopsy, it would have been a heart attack. So again, it was a family member stepping up, going, what really went on here? Can't get an answer. She became a passion. She's totally into measurement. These slides are hers, but she wants to really make sure that you've got the best measure that you've got, and that's, we'll have a chance to refine these measures. These measures are not tied to CFP measures, but they're going to be a public.
Think that's it? Nope.
I'm going to move through this. These were just kind of my driving thing on slides, but I think we did all these. I'll get to Tom's slide by quoting Tom. Then we've gone through a lot of these are just the different roles of patients and families that play in the framework. So it's going to use kind of summarize points, but I think a bit clear. Next slide, please. Next slide, please. Sample toolkit. So there's lots of stuff out there. This comes from the patient-centered medical home, but toolkits for providers, for staff members, for patients, for families. We're going to be able to put together really nice practical. Next slide, please. That focus on the challenges as well as the opportunities we've got to really. This is probably what we're spending a minute on. When we look at the barriers that people face, some of them are physical, the disability, or they just cannot help themselves. They need more support from others. Some of them are psychological, carrying disease burden, the depression that goes along with it, and maybe other issues. Cognitive, health literacy, do we speak English? Do we have basic understandings of our medication? Economic, or do we have enough mind environment? And social, do we live in isolation? And even though we're in a community, we live by ourselves, no one's really watching for us. We don't tell that because we're ashamed. So all those are the barriers that we can kind of use things like TeachBack and other tools to help you understand better what's happening as we have. Next slide, please. This is the slide I was trying to get to. So Tom and I were at a meeting 2 years ago where we've known each other for a long time, and he had to leave early to catch a flight to home, and he just scribbled this down on a piece of paper. And I think to Tom it was really a reflection of the journey that you had taken as a doc, but I captured it because I think it really speaks to where we're going. So this is the history of patient and family engagement according to Tom. The first stage was, we're going to do is for them. It's our job as physicians. They're not, this is role model. Their job is to follow directions. Our job is to fix all the problems. So we're going to do it for them. Why do we really need them as part of this discussion? I want to build an entire organization called patient-based organization. So we didn't bring a single patient into the structure of the organization. This was 1997, and there's no good deeds goes unpunished. We were ticketed 2 years later by every victim support group in the country going, how can you be talking about us not letting us into your room? And when I listened to them, this was my aha moment as a patient advocate. Okay, I'm hearing things from them with Berwick and Lucian Leaf and the other luminaries on my board department because they don't manage the way it's doing. So anyway, that's stage one. Stage two was dropping the wall signs. Okay, we're going to talk to you about this. Safety is now, on everyone's radar screen. We're going to work with you. We're going to bring you in the room. Third was listening to your story.
So again, this is, when we listen to your stories, we learn things and they motivate us. But it sounds that, we're going to listen to your stories. We're going to bring you in to that degree. We'll call you back when we need more motivation. Your job is here to come chin us up, please. But we don't really think of you as much of a partner, other than a motivating partner. Fourth is we start bringing them into our work. And fifth is that we are really partnering with them. They're actually not just into our work at the point of care, but they're part of our structures. They're part of our boards. They're part of telling us what's important to them at a population-based level. And that's where we have, I think, a huge opportunity in this work to really accomplish this. Yes, Karen?
The motto for the patient-centered is nothing about me without me.
Yeah. So, yeah, and it wasn't too long ago that motto. I hope we've made progress in getting that to be understood. I think we're past stage one.
Well, an interesting real in the trenches story, getting practices through connected to the home recognition process, going through this, how to engage the patient, how to use shared decision making, how to develop a treatment plan in collaboration with the patient, exceptionally challenging because the feedback I get from the providers were, that's right here in my notes, that I went through the informed consent with them, and I went through the return of findings, and I said, do you understand this? And they said, yes, it's right here. It's right here. It says that. And I go, let's step back and see what that looks like from true collaboration. And it's very hard because they see themselves on that stage and not integrated in the team. So the approach that we went with was, let's bring the patient into the team as the most important member of their own healthcare team and see them as that. And then what barriers do they have come up when you have them involved in being a member of their own healthcare team. But a lot of them say, well, they don't care. They don't care. Well, that's the hardest hurdle to get over is the provider's perception that the patient doesn't care or doesn't want to be involved.
Right. So Karen, I think one thing that we could do with that experience is, Tom and I look forward. Where's the answer in the room? You've got some experience here that is on the ground. If we could kind of build a story around a physician practice that you've worked with that have kind of had that aha moment or doing it differently, that could be a terrific contribution to this whole room here, to the entire campus PTN, and to we put you on a webinar.
One of the things that we integrated was snippet of motivational interviews, such so that you could at least ask the patient on a scale of 1 to 10, where do you think the likelihood is that you will be able to follow the treatment? Or would, want to engage in. And so it was just a little bit to get them to say, I see, I really need to get a little bit of feedback from the patient in terms, and then that's just the opening door, and so the nose of the camel, that's a big part of it.
I've seen some protocols that are sort of simple that way. Give us the scale, and the next question is probably, well, what more could you do, or what more can I help you do? But if we could invent something like that and test it here, not invent out of scratch, but start with the tool that you've already developed, or one of the ones from the literature, and just use it in our practices and see how it works. Because I think motivational interviewing can be a really big thing, but it can be difficult too. And this has been great. I'm so glad that you spoke up. So thank you. And I'm not going to be quiet because I've taken too much time, and you've had like a lawyer in the front room that's screaming at you.
I want to make a couple of closing reflections on this, and maybe we need to go to lunch. But first of all, I call this slide bucket list slide, and the bucket list slide and the reason is because I didn't even know this slide existed until a week ago. I was in Kansas, and Marty's compatriot was giving this presentation and all this, and I'm just kind of playing. All of a sudden, there's a slide up there with all this wonderful stuff that I said. I don't remember saying it, but But what happened was, and I did remember when it happened and what we were talking about, and Marty kind of described it, and Natasha didn't describe it as well as you did. But the points I'd make on this, I do remember the conversation you and I were having now, and it goes back to Marty and I have both served time on the National Patient Safety Foundation Board of Directors. And Marty was actually the godfather of that and started it, and then I came on the board after him. And
No, I wasn't on the board. I was at the year. You were on the board.
Was it? Okay. Well, I know I was there after you too. But the point I want to make is that we started this thing, and I remember I came on, it was a board of 50 people, big board, and there was one patient advocate. And I remember thinking, whoa, all these people talking all the time, and we're always talking around the patient. And then we went on, and I remember there was a point where Marty was gone, and I was on the board, and we had 3. We were so proud of ourselves. Out of the 2 people on the board, we had 3 patient advocates. 3 patients telling us what was going on, and Marty and I were joking about it. And then the thing that as we were talking about how our journey on patient safety had changed. And I got to tell you right now, the reason we spent a lot of time on this today, and some of you, I know there's different people in here in different positions. There are some of you here that are going, there's a few of you that are going, yeah. And there's a few that are going, there's a lot of junk. And a few that are going, this is soft and fuzzy and really kind of down my scope, and I really don't care. And the point I'm making with you, I want to make a couple of points. I'm going to underscore a couple of things that Marty had said, and then I want to go back to this. But point number 1 is he presented that driver diagram, and we're going to talk about that later. But the content package for TCPI has 3 big categories, 3 big goals that for us to change the way we do things. Number 1 is person and family engagement, and a whole set of skills about how we do team-based care and we execute care differently, and we invade. And frankly, it's not about provider-led care, it's now about patient-centered care. The second one is about using data and data to affect change, and I'm talked quite a bit about that and all that quality improvement stuff, and we'll talk about data this afternoon, but that's just the second category. The third category is about sustainability. How are we going to take the resources we have and actually be able to do this in a sustainable fashion? Now, again, the thing I want to underscore is engagement of the patients, person and family engagement, engaging our communities, the chronic care model, all that stuff. That's where we are now. That's what we've got to do. This is not a sociologic application over care transformation. That's the guts. That's why we just spent a big part of this meeting talking about patient and family engagement. You got a lot of resources in this discussion. Point number 2 is that quote from medical economics or whatever it was, healthcare, yeah, which is basically person and family engagement is the blockbuster drug of the next century. You know what that says? This isn't about this is not about provider-driven care, it's about patient-driven care. Now that's said. So everybody got it that this isn't just like one of those soft and fuzzy frosting on the cake discussions that we have to have. This is core.
Yeah, it's done in this century. We're 50 years into it.
Yeah, but this is core. Yeah. We won't be successful. You won't move your numbers if you aren't figuring out a new way of doing this. Remember that thing I said about the social 30% of it is actually healthcare. When we talk about healthcare reform, we can be under the spotlight from the feds. Right. But 10% of the cost is going to be driven outside of our environment, and we will be responsible for figuring out how to engage that and move that differently. Okay? This is core. Now, so Marty and I, we were kind of kicking it around, and I scribbled this down like, geez, Marty, on a whiteboard. But I scribbled this down because we were in some big patient family engagement meeting with all these people talking about stuff, and I said, you know, it's been a journey for me. It's been a journey for me to understand this. I've been a patient and family engagement guy, and I didn't get it. You know, frankly, I was committed, but I was committed to do all this wonderful stuff for my patients, to take care of my patients, to listen to my patients, I'm providing patient-centered care, which meant I'm providing patient-centered care. That's phase 1. That was me, okay? Now that's where I was, and I got to tell you, this applies to kind of the national discussion around, the clinical discussion around patient and family engagement. This also applies to this. This is like the stages of grieving for death and dying. This is like the 5 phases that practices are going to have to go through. They're going to think they got it, and they're just going to be mad. Okay? But they're going to have to go through these phases. First of all, matter of fact, you're going to be mad that, what do you mean I'm not listening to you? We got to get through. You got to make the understanding that we're not really we're doing things for them, not with them. Once we get past that and begin to open up, we can start to drop the walls and actually invite them in. Marty talked about patient and family engagement councils, and most of you are kind of going, "Oh, that would be weird." How would we do that? Oh, I can invite a couple of. Matter of fact, you probably were thinking, well, who are the 2 or 3 friendly people to our practice that we could bring in and ask them safely? They'd be safe. But that's a good place to start. But we've got to begin to invite them into the room. Remember, the room is like our room, but we're inviting them into our environment. The next phase, what happens is they're going to actually start to tell you stuff, and you're going to start to hear the bad stories. You're going to start to hear the things that you didn't see before and you didn't appreciate before, and you're going to be embarrassed. And then what you're going to want, as a matter of fact, and there are going to be patients that are going to come to you, and they're going to tell you these terrible stories, and they're going to find a catharsis as they bleed all over you. Matter of fact, you're going to find patients who that's their primary thing. They just want to come in, they're resentful. They just want to bleed all over you. And that's good, but it doesn't really change things. It just creates a dialogue. So you're going to have to begin to get those stories, and what happens is when they bleed all over us, our providers begin to go, okay, I guess we really do need to change. Now, what do we do? Give me some of those patient and family engagement. How many of those patient and family engagement things do I have to do? Back to the volume-based stuff.
But Tom, let me just temper this. You're also going to hear questions. You're going to hear people about those and reminders, whatever. But it is a long, and then bringing that forward to providers to say, for stage 3, here's some yeah, so it might declare a full patient family engagement tribe, but it's patients that say, savvy and are going, I care the supercomputer when I talk about that's coming. There's practices, Kaiser Permanente is working in the whole HIT community, working again, the health industry, patient family engagement, but a year ago, about really meeting the expectations of patients and families that can use technology, or helping those that can. But I think that's going to be a big dimension of this.
The apps thing, who's using apps? I mean, we try to figure out as fast as we can. So the guys, the millennials, and don't forget, the millennials want information. They don't really want you. They want the information. So, and primarily for self-management. So the real opportunity with the apps are going to be self-management, capturing that information into how we do this stuff. So it is a family engagement tool, but it basically is self-management.
Well, what I like about it is a lot of the programming. If you think about what programmers who are making a new iteration of the cell phone every 6 months doing, they're trying to make it as user-friendly as possible. They are building human factors in. Do we use pictures here? Do we use words? What do people pay attention to? Do we use emojis? And so that whole industry can actually help us. They're going to be, how do you get complex information across simply when everyone is walking around with this computer in their pocket? I think it's going to be a huge portion of our future.
Right, and a lot of providers are really tech savvy as well, but they also have a limited amount of time in their day. Right. So that's if there is a tribe, as you say, it's kind of monitoring all that development. Some of those things are need to be brought forth through the PTN workflow.
Again, you just kind of build again the page, and we're going to really punch you. But that's why we're here. So but again, what we need to do, what resources do we have? Let's cross-pollinate this. It's time for lunch.